Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 72, that is the fluid and electrolyte balance. In this lecture we will cover the total body water, intracellular fluid, extracellular fluid, normal exchange of fluid and electrolytes, electrolyte balance, that is the potassium, sodium, chloride, its hypo and hyper conditions and their treatments, parenteral fluid therapy, that is the dextrose, isotonic solutions and ringer lactate solutions and other solutions, post-operative fluid regimen. All these points is covered in this lecture. Let's start with the fluid and the electrolyte balance. Total body water, that is the TBW. The total body water is measured by the deuterium oxide dilution, and treated water accounts for 60% of the body weight in youngs and 50% for young adults females. A normal variations of plus or minus 5% applies to both groups. The total body water is divided into two functional compartments. First is the intracellular fluid and second is the extracellular fluid. Intracellular fluids constitutes the fluids within the body's total cell population, and this is about the 30 to 40% of the body weight. And second is the extracellular fluid, which represents 20% of the body weight, is divided into first intravascular fluid. This represents 5% of the body weight, and second is the interstitial and extracellular fluid, which represents 15% of the body weight. It should be remembered that intracellular fluid is larger subdivision and constitutes 70% of the total body water, whereas the extracellular water amounts to about 30% of total body water and actually forms the suitable environment for the cell of the body. Now here is a good image showing the balance of the electrolytes and water should be maintained. Now the intracellular fluid. The intracellular fluid is measured by subtracting the extracellular fluids from the measures and total body water. If the chemical composition of the intracellular fluids is studied, it will be found the potassium and magnesium are the principal cations, whereas the phosphates and proteins are the principal anions. The intracellular concentration of the potassium is approximately 125 milliequilibrium per liter, magnesium is approximately 40 milliequilibrium per liter, and sodium is 10 milliequilibrium per liter. Magnesium is approximately 40 milliequilibrium per liter and sodium is about a milliequilibrium per liter. The concentration of the phosphates is about 150 milliequilibrium per liter intracellular of fluid, whereas the protein constitutes 40 milliequilibrium per liter of intracellular fluid. Now the extracellular fluid, this constitutes about 30% of the body water. It can be divided into three subdivisions. Intracellular fluids, which is situated within the blood vessels, constitutes 7% of the total body water and 4% of the body weight in the normal adult. Second subdivision is the interstitial or the extravascular fluid, which lies outside the blood vessels and around the cells of the tissue of which it forms the immediate environment. It constitutes 70% of the body water or 7.5% of the total body weight. And the transcellular fluid, which includes fluid which is the extravascular but not interstitial, that is the cerebrospinal and synovial fluid, urine in the collecting tubules and urinary tract fluid in the duct of the glands, in the eyes and ears, in the alimentary tract, accounts for 6% of total body water and about 3.5% of total body weight. Of these, the transcellular fluid is relatively non-functional. The most important cations of extracellular fluid is sodium, which constitutes 140 milliequilibrium per liter, whereas the potassium 5, calcium 3 milliequilibrium per liter and magnesium only 2 milliequilibrium per liter are the other cations available in the interstitial fluid. The principal anions are chloride, that is the 140 milliequilibrium per liter, and bicarbonate 30 milliequilibrium per liter. There are minor differences in ionic composition between the plasma and the interstitial fluid due to the differences in the protein concentration, as the plasma contains higher protein content. As the plasma contains higher protein content, organic anions, the total concentration of cation is higher in plasma than in the interstitial fluid. Now the normal exchange of the fluid and electrolytes. Water intake. Normal individual consumes an average 2000 to 2500 ml of water per day. This intake is derived from two sources, from the exogenous source and endogenous source. First, exogenous source, this water is either drunk As various drinks are ingested in solid foods, about 1200 ml water is drunk every day from the various beverages, whereas about 1000 ml is derived from the solid foods. Now the endogenous water, this water is released during the oxidation of the ingested food, and the amount is approximately 300 to 500 ml per day. During starvation, this amount is supplemented by water released from the breakdown of the body tissues. It must be remembered that water requirements of the children are relatively greater than those of adults, as the water content is higher in respect of their total body weight. The metabolic activity is greater in children due to the growth, and the immature kidney and the children are poor in concentrating ability. Now the water output. Water is mainly excreted by the three routes. First is the urine, second is the feces, and third is the insensible loss. First, urine. The normal urinary output is about 1500 ml per day. The amount of course varies with the amount of the intake as various drinks by a person. Now second is the feces. Water loss in stool is about 100 ml to 200 ml per day. In diarrhea, this amount is multiplied by the number of the stool as also their fluidity. Third is insensible loss of the water from the skin and the lungs. About 900 ml of water is lost from the body as insensible loss. This loss mainly occurs through the skin, that is the 75%, and through the lungs 25%. The insensible loss of water through the skin is not from the evaporation of the water from sweat glands, but from the water vapor formed within the body and lost through the skin. This average loss through the skin between 500 to 1000 ml per day. This is less in temperature, climate, and more in tropic countries. Fewer insensible loss of the water through the skin increases. This loss increased by about 100 ml per degree of fever per day. About 400 ml of water is lost is expired air every day. In case of the hyperventilation and increased respiratory rate, this loss is increased. In dry atmosphere, this loss is more than in wet atmosphere. Now, the salt intake and output. In normally, individual salt intake in food varies approximately from 80 to 100 millikilograms, that is averagely 5 gram per day. Output of salt in urine is averagely normal individual is about 70 to 90 millikilograms. In feces, excretion of salt is quite negligible. Salt is also excreted by the sweat, which represents a hypotonic solution of salt with an average sodium concentration of 15 milligrams per liter. Sweat is a major source of loss of salt in tropical countries. Salt loss by kidneys also vary considerably. About 100 milligrams of sodium is excreted in the urine in normal individuals in temperature climate. Now the water deficit and excess. Water or volume deficit. The extracellular fluid volume deficit is a common fluid disorder in surgical patient. The fluid is deficit is a normal water only, but water and electrolytes in approximately the same proportion as they exist in normal extracellular fluid. The causes of such deficits are difficulty or inability to swallow may be due to the painful conditions of the mouth and pharynx or obstructions in the esophagus. Second is the loss of gastrointestinal fluid due to the vomiting, nasogastric suctions, diarrhea, and fistula drainage. Third is the sequestration of the fluid in soft tissue injuries and infection. Fourth is the intra-abdominal and retroperitoneal inflammatory process and peritonitis. And next is the intestinal obstruction. Fifth is the burn, and sixth is the pure water loss may occur from the lungs after tracheostomy. This loss is about 500 ml more than the normal insensible loss due to the tracheostomy. Now the clinical features of the water deficit and excess. The main manifestations of loss of the blood volume are reflected early in the central nervous system and cardiovascular system. The CNS symptoms and signs are weakness, apathy, sleepiness, anorexia, and intense thirst. In more severe conditions, the CNS symptoms and signs become decreased, like the tendon reflexes, stupor, and even coma. The cardiovascular symptoms and signs are mainly due to the decrease in plasma volume, that is the hypotension, collapsed veins, tachycardia, cold extremities, steady pulse, and cutaneous lividity. Now the treatment. Obviously, intake of water should be the increase. Water, dextrose or saline should be given hourly or even half hourly. Now the water or volume excess. First we see the water deficit, and now the water excess. In contradiction to volume deficit, volume excess is usually iatrogenic, that is the overhydration. First is the excessive amount of intravenous fluid has been administered. Colorectal washout with plain water when used in patients with Hirschsprung disease may cause water excess or intoxications in children. When water has been used instead of saline in total bowel wash prior to colonic surgery. Next is the excessive irrigation of the fluid during transurethral resections of prostate. In two pathological conditions, volume excess may occur. First, the secondary to renal insufficiency, and second is the ADH secreting tumors, that is the oat cell carcinoma of the bronchus. Now, the clinical features of the water excess, that is the, in this condition also mainly the CNS, cardiovascular and the gastrointestinal systems are affected. There is an increased venous pressure with increased cardiac output, distension of the peripheral vein, pulse, high pulse pressure and increased pulmonary second sounds are some of the features noticed in this condition. Laboratory investigations show how hematocrit and a high mean corpuscular volume, that is the MCV, the serum sodium and other electrolytes also become low. Now the treatment, fluid intake should be stopped, particularly the intravenous fluid. Even with this, the patient still remains stupor, particularly due to the renal insufficiency, that is the 200 ml or hypertonic saline 5.85 solution should be given intravenously. This may be added with a diuretic. Now the next point of this lecture is the electrolyte balance. As mentioned earlier, the both extracellular and intracellular fluids contain certain cations and anions. Cations are electropositive and anions are the electronegative. These are collectively called electrolytes. These electrolytes are maintain the certain concentration of both extracellular and intracellular fluids in the body. In normal individuals, the balance is always maintained and this is known as the electrolyte balance. To understand this process, one has to know the various electrolytes of these fluids, their various concentrations and their exchanges to maintain equilibrium in extra and intracellular fluids, that is the sodium, potassium and magnesium and chlorides. First, the sodium. Sodium ion is the mainly responsible for osmolarity of the extracellular fluids. About 40% of the total body sodium is in the extracellular fluid, 9% is in the intracellular fluids and remaining 47% is in the bone. The total content of the sodium in the body is about 90 grams. Second is the sodium in bone. The importance of the sodium in bone, about the half of it is osmotically inactive, does not take part in the exchange and insoluble in the acid. Loss of the sodium from bone has been noticed in acute sodium depletion or with adrenal hypofunction. Similar shift of the sodium may occur in patients, particularly after losses by the diarrhea or sweating, in diabetic acidosis or prolonged restrictions of the sodium intake. And second is the sodium conservancy following trauma. Following trauma of any kind, there is a time, the length of which varies directly with the degree of the tissue damage in which there is a almost number of excision of the sodium. Now, the condition, that is the hypo-natraemia. The causes of the hypo-natraemia can be divided into two categories. That is the first is the real sodium depletion, in which the both sodium and water is lost, and second is the apparent sodium depletion, in which there is a sodium dilution or loss of the sodium in comparison to the water. The sodium level should be at least less than 130 milliequilibrium per liter in extracellular fluids to be called hypo-natraemia. Now the real sodium depletion is due to the burns, loss of large quantity of sweat which is replaced by the drinking water only. Second is the apparent sodium depletion may be caused when the above losses have been replenished by the admission of water and glucose solutions. This is also noticed after operation when excessive quantity of glucose solutions is administered. Clinical features of the hypo-natraemia is, these are almost similar to the extracellular dehydration, that is the eyes are shrunken and the face is drawn, the expression is anxious, the tongue is dry, hard and reddish brown in color. Though patient is usually not thirsty, the skin is dry, wrinkled and the subcutaneous tissues feel lax. Now the treatment is, the first step in the treatment is to administer the normal saline, that is the 0.9% through the IV drip. In the beginning, the infusion rate must be rapid and to make good sodium loss, Now the next point in the sodium, that is the hyper-natraemia. Hyper-natraemia or sodium excess can be also from the renal causes and apparent causes. First, renal causes. Here the sodium content of the body is really increased. The main causes of the iatrogenic, that is the excessive administration of the normal saline solution intravenously during the early postoperative period. The result of the hyper-natraemia is overloading of the circulation, as excess sodium will increase osmotic pressure within the capillaries and will draw excess water into the circulation from the interstitial tissues. This may be result in edema of the dependent tissues and also edema of the suture lines after abdominal operations. There is also danger of the pulmonary edema. Now second point in the hyper-natraemia is the apparent causes for the hyper-natraemia. Sodium excess may occur in true dehydration when the total body water content is reduced, but the sodium content remains as normal. This may occur if there is a loss of both water and sodium, but the loss of water is greater than the sodium. Now the clinical features: puffiness of the face, pitting edema in the sacral region and around the ankle, and the main features of this condition, that is the polyuria, are also noticed. Now the treatment of the renal hyper-natraemia is stoppage of the infusion if there is the edema, and diuretics may be prescribed. Treatment of apparent hyper-natraemia should be according to the merit of the individual's cases. So these decisions should be taken by the surgeon or a physician. Now potassium. This is a mainly intracellular cation. Nearly 98% of the total content of the potassium in the body is 130 gram is in the cells and intracellular fluids. Only 2% is in the extracellular fluids. 3/4 of the intracellular potassium is in the skeletal muscles. Potassium is a predominant cation of the intracellular fluids and amounts up to 2/3 of the total active intracellular cations, remainder being the magnesium. Now the normal intake of and output. A healthy adult can consume about 2 to 3 grams of the potassium each day, and almost the same quantity is excreted in the urine every day. A very small quantity is excreted in feces and sweat. In patients with anuria, the accumulation of the potassium occurs in the extracellular fluids and raises its concentration to a toxic level. It is probably the commonest cause of the death in this condition. Potassium excretion in the urine is excreted by the administration of the ACTH, cortisone and deoxycortisone, aldosterone and other diuretics. The normal range of the potassium concentration in the plasma is from 3.8 to 5.1 milliequivalent per liter. Values of less than 3.5 milliequivalent per liter or more than the 7 milliequivalent per liter are considered to be highly abnormal. Now the potassium deficiency or hypo-kalaemia causes. First is the following causes, which includes operation. There is the increased mobilization of the intracellular potassium to extracellular space, and there is also increased excretion of potassium by the kidneys. It must be remembered that the immediate post-operative period there is the excessive loss of the potassium, but the sodium is conserved as body reserve of potassium is quite good. So therapeutic administration of potassium is not required before the 3rd day of the continuous parenteral nutrition. So surgeons should be always remember this. In starvation, as the result of the catabolism of protein tissues, potassium and nitrogens are excreted in the urine in the same proportion as they are found in the skeletal muscles. And third reason of the hypokalaemia are in loss of the gastrointestinal secretions by external fistulas, that is the duodenal fistula, ileostomy, etc., and through the diarrhea caused by the ulcerative colitis and villus tumor of the rectum, there is excessive loss of the potassium as these fluids contains potassium concentration twice as that of the plasma. If nasogastric aspiration is continued for a long time, which fluid replacement by the intravenous isotonic saline solutions, there is a chance of the potassium depletion. Now the clinical features of the hypokalaemia. Potassium depletion is a gradual onset of the drowsiness, muscular hypotonia and weakness is an outstanding physical signs. The deep reflexes may be absent. Incontinence of urine is common. Potassium depletion causes diminished motility of the intestinal musculature, which results in the accumulation of the intestinal secretions. The peripheral blood pressure is lowered and the pulse rate becomes slow. Potassium depleted patients are often very thirsty and may drink large quantity of fluid. Now the treatment of the hypokalaemia is replacement of a large deficit of the potassium involves the administration of the sufficient potassium and its transfer into the depleted cells. Whenever possible, potassium salt should be administered by the mouth. Oral administration of the potassium is always chosen first. They avoid the danger of increase of potassium concentration with intravenous administration of solutions of potassium salts. To prevent increase of potassium concentration above 7 milliequivalent per liter in the extracellular fluid, this is a toxic level and which cause cardiac arrest. One must ensure adequate flow of urine before administering potassium intravenously. Intravenous administration of potassium salt is dangerous and should not be treated as a matter of routine. The quantity to be given and the rate of its administration should be carefully monitored. Now the next point is the potassium retention or hyperkalemia. Hyperkalemia is a mainly iatrogenic and is due to the excessive intravenous infusion of the potassium salts. This is usually associated with the severe oliguria, anuria and reduction in the volume of the extracellular fluids may raise the potassium concentration in the blood. Clinical features: the gastrointestinal symptoms include nausea, vomiting, intermittent interstitial colic and diarrhea. Cardiovascular signs are low heart rate with irregular beats, low blood pressure, poor peripheral circulation and cyanode skin. There may be also some mental confusion, apathy, sensory disturbances and weakness of limbs. The electrocardiography changes that in the ECG are particularly characteristic in hyperkalemia. When the concentration goes up to the 7 mg per liter, the findings are high peak T wave, widened QRS complex, increased PR interval and depressed ST segments. Gradually, there will be the disappearance of the T waves, heart block and the cardiac arrest in diastole. The treatment of the hyperkalemia is firstly the exogenous administration of the potassium should be stopped. Temporary lowering of serum potassium and suppression of the myocardial effects of hyperkalemia can be accomplished by the intravenous administration of 10% of solutions of calcium gluconate or chloride 10 to 30 ml over 15 to 30 minutes or in the 1 liter of the intravenous fluids. The urinary volume and excretion of potassium is promoted by rapid infusion of 5% glucose. Administration of glucose stimulates insulin releasing, which augments cellular potassium intake. Addition of insulin 1 unit per 5 gram of glucose is often recommended. Alkalization of the extracellular fluid with either sodium lactate or bicarbonate promotes transfer of potassium into cells. Calcium ions do not affect serum potassium concentration, but does counteract the effect of the hyperkalemia on cardiac cells. It cannot be emphasized to her that the above mentioned maneuvers are temporary and give adequate time of removal of excess potassium by cation exchange resins, peritoneal dialysis or hemodialysis. When associated with the oliguria, urinary output may be increased by infusion of hypertonic saline in the form of 50 gram glucose and 50 units insulin in 1 liter solution. Later on, of course, cation exchange resins and dialysis should be called for. Now, the hypocalcemia, the common cause includes the acute pancreatitis, acute and chronic renal failure, pancreatic and small intestinal fistula, hypoparathyroidism. Transient hypocalcemia may occur following removal of the parathyroid edema in the hyperparathyroid patient. Now, the clinical features of the hypocalcemia are includes numbness and tingling sensations in the circumoral region and the tips of the fingers and toes. There will be hyperactive tendon jerks, muscle cramps with carpopedal spasm and tetany. The Chostek's sign will be positive. Now, the treatment in the hypocalcemia is intravenous administration of the calcium gluconate and the chloride. Calcium lactate may be given orally with supplements of vitamin D. Now, the hypercalcemia. A serum calcium concentration above 15 mg per 100 ml is a serious condition and require immediate treatment. Majority of these patients show vigorous volume depletion due to the excessive vomiting. When the serum calcium level goes above 16 mg, it may cause death. The main causes of the hypercalcemia are hyperparathyroidism, cancer with the bony metastasis, sarcoidosis and myelomas. Clinical features of the hypercalcemia is anorexia, nausea and vomiting, fatigue, lassitude and weakness are the main symptoms in the early stage. Gradually, headache, pains in the back and extremities, thirst, polydipsia and gradually become worse with more serum calcium levels to lead to the stupor and finally coma. Now, the treatment of the hypercalcemia is oral or intravenous inorganic phosphates effectively lower serum calcium level by inhibiting bone reabsorption and forming calcium phosphate complexes that are deposited in the soft tissue and bones. So, intravenous phosphates should be given slowly over a period of the 12 hours once daily for no more than 2 to 3 days. Corticosteroids decrease reabsorption of calcium from bone and reduce intestinal absorptions of vitamin D. Concomitant use of the large doses of intravenous furosemide may be recommended to increase the urinary calcium excretion, but replacement of fluid and other electrolytes are required to make good the losses. The definitive treatment of hypercalcemia is a hyperparathyroidism is immediate surgery. Now, the parenteral fluids therapy, administration of fluid by any route other than the alimentary canal, that is the intravenous, intramuscular, subcutaneous or into the bone marrow is called the paraenteral fluid therapy. The Greek word enteron means the intestine, paraenteron means beside the intestine. So, parenteral fluids by any route except intestinal. Various solutions have been used to maintain the fluid and electrolyte balance in the body. Majority of these solutions are introduced intravenously, which is by far the most common method of the parenteral administration. It goes without saying that the solutions for parenteral use must be sterile. These should also be free from the dead bacteria and particulate matters. The various solutions which are commonly available in the market for parenteral fluids therapy are 5% dextrose solution, that is also called as a D5, isotonic 0.9% sodium chloride, that is the saline solution. Third is the ringer lactate solution, that is the RL. Dextrose 4.3% with saline, that is the 0.18%, and molar sodium lactate solutions. Now first 5% dextrose solution, that is the D5. It is an isotonic solution which supplies calorie but not electrolytes. So this solution can only be used when the patient does not require any electrolytes but a solution of replenish his blood volume along with some nutrition. Second is the isotonic 0.9% sodium chloride saline solution. This solution is isotonic and contains sodium and chloride in the concentration almost similar to that in plasma. In the plasma, the sodium concentration is about 140 milliequivalent per liter and chloride concentration about 100 milliequivalent per liter, potassium concentration about 5 milliequivalent per liter, and bicarbonate concentration, that is the SCO3, about 24 milliequivalent per liter in the normal saline or 0.9% sodium chloride solutions. The concentration are 154 milliequivalent liter of sodium and 154 milliequivalent liter of the chloride. It is good available solution for replacing the gastrointestinal losses either by the vomiting or by the nasogastric aspiration and through the intestinal fistula. It must be remembered that these solutions should not be used in the first 24 hours after the operation due to the natural sodium conservations in the body. If in the post-operative period sodium solutions is given, then there is a hyper chances of the high hyper-natraemia. So avoid post-operatively this solution. However, this solution is ideal to use the extracellular fluid deficiency in presence of the hypo-natraemia and the hypo-kalaemia and metabolic alkalosis. Now the third fluid therapy is the ringer lactate solution, that is the RL. This solution contains 130 milliequivalent per liter of sodium, 109 milliequivalent liter of the chloride, 28 milliequivalent per liter of the SO3, that is the bicarbonate, 4 milliequivalent liter of potassium, 2.7 milliequivalent per liter of the calcium, and 28 milliequivalent of the lactate. The main advantage of this solution is that it has almost similar electrolyte concentration as extracellular fluid and the pH remains normal even if the infused in the large quantities. This solution is the best to be used in hypovolemic shock while awaiting for blood. The chief disadvantage is that it has slight hypoosmolality with respect to the sodium. Now fourth solution is the dextrose 4.3% with saline 0.18%, fifth of the normal saline. This is an isotonic solution in the distinction to 5% dextrose with isotonic saline solution which is hypertonic. It can be used in any case of the hypovolemia where there is not considerable depletion of the sodium and chloride. Fifth is the molar sodium lactate solution. This solution has a sodium concentration of 1000 milliequivalent liter and the bicarbonate concentration of the 1000 milliequivalent liter. This solution is particularly suitable for the symptomatic hypo-natraemic states. Now the last point of this lecture is the post-operative fluid regimen. In the first 24 hours after surgery, there is an increased secretions of aldosterone and antidiuretic hormone. There is a conservation of the sodium and loss of less water than in the normal individuals. 5% dextrose solution is probably the best in this period, that is, and 2 liters with suffice in 24 hours. During the second and subsequent 24 hours period, it is expected that the patient will lose about 900 ml by the insensible loss, which may be increased by the hyperventilation and fever to the maximum of approximately 1500 ml in a day. This loss should be replaced with 5% dextrose solution. Approximately 1 liter of the fluid should be given to replace the volume of urine. On the third postoperative day, it is better to give isotonic solution of 4.3% dextrose and 0.18% saline for 2 liters to combat loss of the sodium through urine and sweat. It is always essential to make a fluid intake and output chart. This will figure in intake, oral intake through intravenous drip. In output chart, urine output and aspiration along with vomits are recorded. To this chart, about 1000 ml should be considered for insensible loss through lungs and the skin, and another approximates 500 to 1000 ml for sweating. Dear students, this point fluid and electrolyte balance is much more longer. I tried here to combat it in this lecture of 35 minutes. Refer the textbook to detail for this point, fluid and electrolyte balance. Dear students, here is the end of our surgery lecture number 72, that is the fluid and electrolyte balance. Thank you.